Chapter 15: Adrenergic Agonists and Antagonists. The central nervous system is the body's primary nervous system and consists of the brain and spinal cord. The peripheral nervous system, on the other hand, is located outside of these two areas, located beyond the brain and spinal cord, made up of two divisions, autonomic and somatic. The autonomic nervous system, also called the visceral system, acts on smooth muscles and glands within the body. And it also has functions including things like the control and regulation of the heart, respiratory system, GI tract, bladder, eyes, and glands. These are things that are functioning within our body that we're not necessarily actively thinking about. When it comes to neurons, there are afferent neurons sending impulses to the central nervous system. From there, they are then interpreted. This is not to be confused with efferent neurons. They receive the impulses, the information from the brain, and transmit these impulses through the spinal cord to the effector organ cells. So afferent neurons send the impulses to the brain, efferent send them out to the rest of the body. When discussing the sympathetic and parasympathetic nervous systems, these act on the same organs but produce opposite responses to provide homeostasis balance. They also have drugs that act on the sympathetic and parasympathetic nervous system by either stimulating or suppressing responses. The sympathetic nervous system is also called the adrenergic system. And within this adrenergic receptor organ cells, there are four types: alpha, alpha 2, beta 1, and beta 2. Let's begin with adrenergic agonists. These are drugs that stimulate the sympathetic nervous system. They mimic neurotransmitters such as norepinephrine and epinephrine, and act on adrenergic receptor sites such as those within the heart, the bronchi, the GI tract, the urinary bladder, and the ciliary eye muscles. Within the four main receptors are, again, alpha 1, alpha 2, beta 1, and beta 2. Other adrenergic receptors are dopaminergic and are located in the renal, mesenteric, coronary, and cerebral arteries. When dealing with the inactivation of neurotransmitters, inactivation is accomplished by a reuptake of the transmitter back into a neuron, the enzymatic transformation of degradation, and the diffusion away from the receptor. We can also discuss drugs that prolong the action of neurotransmitter, such as inhibiting reuptake or inhibiting degradation. When dealing with the classification of sympathomimetics, we're beginning with direct acting, such as epinephrine or norepinephrine, that directly stimulate those adrenergic receptors. They can also be indirect acting, such as amphetamines, that stimulate the release of norepinephrine from terminal nerve endings. There could also be a mixed action, such as ephedrine or pseudoephedrine, that stimulate the adrenergic receptor sites, but also stimulate the release of norepinephrine within those nerve endings. Catecholamines are chemical structures of a substance, either endogenous or synthetic, and they produce sympathomimetic responses. Endogenous catecholamines, synthetic catecholamines. There can also be non-catecholamines that stimulate those adrenergic receptors. These tend to have a longer duration of action than endogenous. The first drug we'll talk about is epinephrine. It stimulates both alpha and beta receptors. By action, it increases vasoconstriction, increases blood pressure, heart rate, and cardiac output, while also promoting bronchodilation to open up that airway. It's used in things like anaphylaxis, anaphylactic shock, bronchospasm, status asthmaticus, cardiogenic shock, cardiac arrest, and it has a very rapid peak in onset. The side effects would include things like cardiac dysrhythmias, palpitations, tachycardia, hypertension, dizziness, headache, nausea, vomiting, agitation, restlessness, tremors, hyperglycemia, and oliguria. You can also have drug interactions with things like beta blockers, decreasing the epinephrine action, and digoxin, causing cardiac dysrhythmias. Tricyclic antidepressants and MAOIs also can intensify and prolong its effects. Another drug you'll see with a wide range of uses is clonidine. This is a selective alpha 2 adrenergic agonist used to treat hypertension, It can also be used to treat things like motion sickness or airplane sickness. And it has side effects including dry mouth, sedation, bradycardia, and hypotension. When dealing with an adrenergic agonist, we're focused on perfusion. We want to record baseline vital signs for future comparisons while also assessing the patient's drug history. We're also going to look at things like decreased tissue perfusion, hypotension, and generate solutions such as the patient's vital signs will be within normal range. We would, again, record those patients' vital signs carefully when dealing with any adrenergic agonist. Be taking careful notice of symptoms like tachycardia, palpitations, tremors, dizziness, hypertension, increased blood pressure, and dysrhythmias. We also want to monitor the IV site carefully for any infiltrations, while also avoiding cold medicines and diet pills if the patient's hypertensive. Also, if the patient has coexisting conditions like diabetes, coronary artery disease, or a history of dysrhythmias. Avoid continuous use of adrenergic nasal sprays as well. On the opposite side of this would be adrenergic antagonists, also called adrenergic blockers or sympatholytics. They block the effects of adrenergic neurotransmitters, such as blocking alpha and beta receptor sites directly by occupying those receptors. They can also block indirectly by inhibiting the release of neurotransmitters like epinephrine or norepinephrine. Next would be alpha adrenergic antagonists, also called alpha adrenergic antagonists, adrenergic blockers, or alpha blockers. These are drugs that inhibit a response of alpha adrenergic receptor sites, like selectively blocking an alpha 1, non selective blocking alpha 1 and alpha 2. These work to promote vasodilation while decreasing symptoms of things like BPH or PVD. They work to promote vasodilation while also causing decreases in blood pressure by relaxing that smooth muscle. It can have side effects ranging from dizziness, orthostatic hypotension, and an increased pulse rate that may result, especially when the patient is standing up. They can also be used to treat things like peripheral vascular disease, again, by relaxing that smooth muscle and helping to open up that vasculature. Next, beta adrenergic antagonists, or as you may have already heard of them, beta blockers. These decrease the blood pressure and the heart rate. There could be non-selective beta blockers, such as blocking the beta 1 or blocks the beta 2, which would include things like bronchoconstriction, making sure to use cautiously in patients with COPD and asthma. And this is a thing you're going to see come up a lot. We'll talk about it much deeper when we get to our cardiac sections. Beta blockers are contraindicated for patients with asthma because, again, they cause bronchoconstriction. With asthma, this patient's already at an increased risk of bronchoconstriction. The ability of certain beta blockers to bind with a beta receptor to prevent strong agonists from binding with that receptor. And there's also going to be things like non-selective beta blockers like carvedilol or selective beta blockers like acebutolol. And these are all going to vary depending on which receptors. Are they selective? Are they non-selective? By selective, are they only targeting certain receptors? Or non-selective, are they targeting all of our beta receptors? In the case of selective beta blockers, this would include drugs like metoprolol or atenolol that you may have heard of. And these are selective because they block only the beta 1 receptors. They work to decrease the blood pressure and heart rate and tend to have fewer side effects than some other options. Keep in mind that it can have drug interactions with NSAIDs, and we want to use it carefully with other antihypertensives to prevent hypotension. When giving any beta blocker, the side effects we need to be aware of, your top priority is going to be bradycardia. Especially if we're sitting on NCLEX ATI, the answer is always to get that apical pulse for 1 minute so we can accurately identify that heart rate before we give any beta blocker. We also want to be on the lookout for things like hypotension, dysrhythmias, palpitations, dizziness, orthostatic hypotension, drowsiness, fatigue, depression, and peripheral edema. Adrenergic neuron antagonists, also known as adreneuron blockers, block the release of norepinephrine and are used to decrease blood pressure. They reduce the serotonin and catecholamine transmitters, as well as the depletion of these neurotransmitters that may lead to severe mental depression.
They work under the concept of perfusion, and it's key for you as the nurse to recognize cues and obtain those baseline vital signs as well as an ECG and help determine what drugs the currently takes that could be an interaction. When monitoring the vital signs, report marked changes such as a significant decrease in blood pressure and heart rate. Also, assist the patient with ambulation to avoid falls from orthostatic hypotension. You should also advise the patient that the therapeutic effects of an adrenergic neuron antagonist may not occur for 2 to 3 weeks after the initiation of therapy. And this is a phenomenon you'll see often with psychiatric medications and antidepressants as well. For our first practice question, when teaching a patient who's been prescribed metoprolol about side and adverse effects, what is the highest priority teaching point? Would that be A, report any complaints of stuffy nose? B, instruct the patient how to take a pulse? C, check for bladder distension? Or D, warn of possible impotence and decreased libido? And that answer is going to be B, instruct the patient how to take a pulse. Remember, airway, breathing, circulation are always your top priority with any NCLEX question. As far as D, that warn the patient about impotence and decreased libido, this is going to be something to definitely be aware of with this, as many guys will completely refuse to take beta blockers. For question two, stimulation of which adrenergic receptor results in dilation of vessels and decreases in blood pressure? That be alpha 1, alpha 2, beta 1, or beta 2? And that answer is going to be A, alpha 1s. For question three, which of the following is a side effect or adverse effect of atenolol that's important for the nurse to teach the patient? That be A, pupillary constriction, B, blood vessel dilation, C, bronchospasm, or D, tachycardia? And that answer is going to be C, bronchospasm. This is especially important with patients that have a history of asthma. And again, our correct answer falls under that airway, breathing, and circulation prioritization. When a nurse is administering epinephrine to a patient during a cardiac arrest, what is the primary desired action of this medication? That be A, stimulate a heart rate, B, decrease cerebral blood flow, C, initiate respirations, or D, increase blood flow to the kidneys? And that answer is going to be A, stimulate a heart rate. Question 5. A patient has been prescribed atenolol. To ensure safe dosing, the nurse teaches the patient to frequently assess what parameter? That be A, daily weight, B, heart rate, C, urine output, or D, body temperature? And that answer is again going to be B, heart rate. Anytime we're dealing with a beta blocker, your priority assessment is going to be to assess that heart rate. Apical pulse, 1 minute. And finally, our last question. A patient is receiving dopamine intravenously. Which drug should the nurse have available to treat extravasation and tissue necrosis? That be A, norepinephrine, B, nadolol, C, phentolamine, or D, clonidine? And that answer is going to be C, phentolamine. In the case of extravasation, should the IV infiltrate, that medication pulling under the skin will quickly kill it, causing necrosis and serious damage. We want to neutralize that as quick as possible. But anyway, that's all I got for this chapter. I'll see you in the next slides.